Assalamu alaikum. Today's lecture is about procedure during ECMO, and it will be about tips and tricks on how to insert the lines and tracheostomy operation while we have ECMO. Patient on ECMO, and we need to do procedure. So we have three questions to answer. Is it necessary? Where we will do? And what about anticoagulation for this patient? Question to answer is it important to do this operation while we are in ECMO? So we need to evaluate the risk benefit for bleeding, or do we need to transport the patient from ICU? These questions should be answered by multidisciplinary team to decide the necessity of the procedure on ECMO. Localization. Is it bedside? Should be done in bedside, in the ICU, or should the patient transfer to OR to receive anesthesia? And if we speak about anesthesia, it will be deep or moderate or light anesthesia to receive. The important part of an ECMO patient is this procedure have bleeding or not. Should we stop the anticoagulation or continue on anticoagulation while we are doing it? We should also having hemostasis at its end. And for this hemostasis, are we in need for electrocautery or hemostatic material or just dressing? We can use antifibrinolytic should be considered during this maneuver. And whatever the maneuver done in OR or an ICU, the one who take caring of ECMO, either a perfusionist or ECMO specialist, should attend the procedure. Procedure didn't require to stop anticoagulation, like for the following procedures, we are not needing to stop anticoagulation, like bronchoscopy or endoscopy. For bronchoscopy, we will use flexible bronchoscopy, and we should take care to avoid trauma to the endothelium, and also it should be done by an expert one. Transesophageal echo inserted and done by expert one, and also cardiac cath. Every procedure on ECMO should be done while the patient on anticoagulation should be done by the most expert one. Arterial line insertion. We can continue anticoagulation. If the patient is in VA ECMO, the ideal place for arterial line is right radial or brachial artery. However, brachial not preferred as because of the perfusion of the arm. Femoral artery is not recommended because of differential hypoxia, and that will not get a good feedback about the brain oxygenation. VV ECMO may have arterial line at any place because the risk of bleeding is high. We should consider using ultrasound. Central venous catheter insertion should be done before insertion of ECMO. Also, perfusionists should be bedside during the insertion. Anticoagulation can be continued. As there is risk of bleeding, ideally, compressible site should be used. We should avoid to use subclavian as we can. Also, when we use inserting the line, we should use ultrasound. Because of the centrifusion pump, ECMO patients are at risk of developing venous emboli. So, during needle insertion, we should temporarily reduce the flow to prevent the air entrapment through the needle. Also, during the insertion, it is very important to put the ports or make all ports are closed. Procedure can be done without anticoagulation. Tracheostomy on ECMO. First, anticoagulation should be held. Why tracheostomy is better than intratracheal intubation? It will decrease the need for sedation, facilitate the secretion clearance and rehabilitation. There is no difference between doing a tracheostomy, either surgical or percutaneous. And also there is no exact time frame confirmed by clinical trials, but it's better to be done on the 7th day. Chest tube insertion. We should first hold anticoagulation. It was found the risk of Hemothorax in pediatric patient in one of the study, 22%. It should be limited for patients who have tension pneumothorax. If the pneumothorax not affecting hemodynamics, we shouldn't use it or do it, and keep the tube till we wean the ECMO, and after weaning we can insert. If the pleural effusion didn't affect the hemodynamics, we should delay the draining of this pleural effusion. Patients requiring surgery. First, hold anticoagulation. Anticoagulation reversal can be accomplished by turning off the heparin infusion and waiting for 2 hours. The decision on which to restart anticoagulation should happen in discussion with surgical team. It's important to do multidisciplinary team to decide the necessity of the procedure or the operation for this patient on ECMO. Another type which is highly needed for ECMO is high-risk thoracic surgery. For tracheal resection or repair, it's required VV ECMO to be in a safe site, as also in this patient will have difficult or impossible airway management, so ECMO will save this operation. Also, ECMO can be used for patients on cardiac surgery and they are suffering from cardiogenic shock, so they will go for a coronary artery bypass, and after bypass and the recovering of the heart, the patient can be weaned from VA ECMO immediately on OR or in cardiac surgery ICU. Besides also Red Book, this is a reference of this lecture. Thank you, and I can receive your questions and comment in blue in the comments.